pial synangiosis with the pia of the cortex, and these are placed in contact with the brain to facilitate ingrowth of new vessels to the cortex. So this is the indirect way of ensuring blood flow. So when you do a direct, you always combining with the indirect and make it a combined procedure. So burr holes are a form of indirect revascularization. So these are the various surgical types of addressing the moya arteriopathy. So the indirect procedures are named so based on the structure you use to ensure the blood flow is adequate. So the first is when you use dura. So that is encephaloduro-arteriosynangiosis. When you use the muscle, that is the temporalis muscle, you add the word myo. So myo-arteriosynangiosis. Some people use the terms edams for it. Sometimes you can do burr holes alone without any vessel synangiosis, and then you have the pial synangiosis. So in addition to the use of vascularized tissue such as the graft where there is a pedicle, so as you can understand, the dura as well as the myo, the temporalis muscle, are all pedicled, and you place the pedicled grafts on the brain. Sometimes you can use a graft which is actually an omentum or a pericranium, and these have also been reported to have some benefit. But I think the most commonly used indirect procedures are EDAS and EDAMS, and pial synangiosis also some surgeons do as an additional step. So as I mentioned, in EDAS the dura is infolded. These black marks which are seen here, you can see that the dura is infolded and placed on the surface of the brain, and then you end up suturing this temporalis fascia or temporalis muscle to this edge of the infolded dura. So as you can see here, after completion of the surgery, you can see nice sutures passing, and the temporalis muscle supply is kept intact by ensuring that it is pedicled. So this is an example of EDAS procedure. So encephaloduro-arteriosynangiosis, where we use the posterior branch of the STA, and there is preservation of the middle meningeal artery, because the middle meningeal artery is the one which supplies the dura. So you should ensure that during the craniotomy you don't affect this, and this middle meningeal artery supply is very important to revascularize the ICA arteriopathy. You should ensure that there is a wide dural opening to ensure that the you can suture the pericranial cuff. You can sometimes place medial frontal and parietal burr holes to ensure that the ACA territory was also addressed, as I mentioned, and subcuticular sutures are placed for the help of scalp suturing. You can do pial synangiosis also, where you see the branches of the STA and you directly suture them with fine suture material onto the pia. An extension of this is only a direct revascularization, where you go beyond the pia and isolate a M4 or a cortical MCA vessel, and you suture the STA to the cortical MCA vessel. By STA I mean a